You wake up, it is 6 in the morning. Before your eyes even open, you already know it is going to be one of those mornings. Your lower back is stiff like concrete. Your hips feel like they belong to someone 20 years older. Your knees creak when you swing your legs over the side of the bed, and for the first 30 minutes of your day, you are just trying to function. So you do what most people do. You stretch a little. Maybe you take an ibuprofen. You tell yourself it is the weather or the mattress or that you just slept in a bad position. And it helps, just enough. Just enough that you can get on with your day and forget about it. But then it comes back, tomorrow, and the day after, and slowly over months, it is not just the mornings anymore. It is after sitting too long, after a short walk, after doing absolutely nothing. You go to your doctor and you get the standard answer: inflammation, arthritis, normal wear and tear for your age. You get a prescription, you get a referral to physiotherapy, you do the exercises for 2 weeks and stop. And here you are, right back where you started, except a little worse. This is not bad luck, this is a predictable outcome of treating a systemic failure as though it were a local mechanical problem. Here is what almost nobody tells you: morning pain after 60 is not just joint degeneration. It is not simply cartilage thinning or the inevitable price of aging. It is a sign of a compound systemic failure, a breakdown in circulatory delivery, nocturnal tissue repair, and low grade chronic inflammation that has been accumulating for years, possibly decades. When you understand those three mechanisms and address them directly, you are no longer managing symptoms. You are working on the actual problem. If this kind of clear, practical health information is what you are after, subscribe and hit like. It helps more people find this channel. The goal here is 100,000 subscribers. You are part of getting there. So let us go back to the beginning. What actually is morning pain and why does it get so much worse after 60? During healthy sleep, your body enters an intensive repair phase. Synovial fluid, the lubricating liquid inside every joint capsule, gets replenished. Collagen synthesis ramps up. Inflammatory byproducts from the previous day get cleared through your lymphatic system. Growth hormone pulses, primarily during deep sleep, drive tissue recovery in your tendons, cartilage, and spinal discs. This is not passive rest. This is active biological maintenance. Your body is supposed to wake up more repaired than when it went to sleep. But here is where the system starts breaking down. There are three main mechanisms driving nocturnal and morning pain, and most people have never heard of the first one. The first mechanism is nocturnal vascular insufficiency. Most people blame their morning stiffness on joint degeneration, but the actual driver is often microvascular. During sleep, your blood pressure drops, your cardiac output slows, and blood flow to peripheral tissue, particularly to the small capillaries feeding joint linings, spinal discs, and connective tissue, drops significantly. In a 30-year-old, this is handled easily. The capillaries are elastic, the blood is fluid, the delivery recovers quickly when you begin moving. But after 60, capillary wall rigidity has increased due to calcification and reduced nitric oxide production. Your blood viscosity is higher due to lower hydration status, because the thirst mechanism becomes measurably blunted after age 50. And this means that during the very hours when your joints need the most delivery, they are getting the least. The tissues arrive at morning partially hypoxic, poorly cleared of inflammatory metabolites, and under-repaired. That stiffness, that ache, that concrete feeling, that is tissue that spent 8 hours in relative ischemia. This is not theory, this is microvascular physiology, and it is almost never mentioned in standard clinical consultations about joint pain. The second mechanism is the failure of the nocturnal anti inflammatory cycle. Cortisol follows a circadian rhythm. In a healthy adult, cortisol levels begin rising at approximately 4 in the morning, peak around 8, and this morning cortisol surge is actually profoundly anti inflammatory. It suppresses interleukin 6 and tumor necrosis factor alpha, two of the primary cytokines responsible for joint inflammation. But chronic psychological stress, disrupted sleep, elevated evening cortisol, and the general dysregulation of the hypothalamic pituitary adrenal axis that accumulates through decades of poor sleep hygiene mean that by your 60s, this cortisol rhythm is often flat or inverted. Your 4 a.m. cortisol surge is blunted. The anti inflammatory signal does not fire at the right time. So you wake into a cytokine environment that has not been cleared. The inflammation from the day before is still sitting in your joints at 6 in the morning. Let that land for a moment. Your own body has an internal anti inflammatory mechanism that is supposed to run while you sleep, and in most people over 60 with chronic pain, it is significantly impaired. The third mechanism is collagen degradation outpacing synthesis. After age 40, collagen synthesis declines at approximately 1% per year. After 60, this decline accelerates further, compounded by low vitamin C intake, because ascorbic acid is a rate limiting cofactor in the hydroxylation of proline and lysine during collagen formation, and by elevated homocysteine levels, which directly interfere with collagen cross linking. There is a persistent myth worth addressing head on. Many people believe that joint pain after 60 is simply about calcium and bone density. That is not wrong, but it is dangerously incomplete. The majority of what you feel as morning pain originates not in bone but in connective tissue, the tendons, ligaments, joint capsules, and cartilage matrix, and those tissues are critically dependent on collagen integrity. Addressing bone density while ignoring collagen turnover is like fixing the walls of a house while the foundation rots. Now let us get into the 5 step plan. Each of these steps targets a specific part of the problem. Together they work as a system. Step 1. Restore nocturnal tissue perfusion through pre-sleep hydration and blood fluidity. The mechanism here is microvascular delivery during your repair window. Most people over 60 are chronically underhydrated without knowing it because the thirst reflex deteriorates with age. This is clinically documented. It is called hypodipsia of aging, and it means you cannot trust your body's signals. The target is 30 milliliters per kilogram of body weight per day, consumed progressively, not all at once. Critically, drink 300 milliliters of water with a small amount of sodium, 200 milligrams, approximately 90 minutes before sleep. This is not just hydration. The sodium holds water in the vascular compartment and supports overnight tissue perfusion. There is a persistent myth that drinking water before bed will simply send you to the bathroom all night. In practice, pre sleep hydration divided appropriately does not significantly interrupt sleep in most people, and the tissue repair benefit is substantial. Additionally, omega 3 fatty acids, specifically EPA and DHA, at a combined dose of 2 to 3 grams per day from triglyceride form fish oil, measurably reduce blood viscosity and improve microvascular flow. Omega 3s are not just anti inflammatory, they are rheological. They change the physical properties of your blood. Step 2. Rebuild the cortisol rhythm to restore your body's nocturnal anti inflammatory cycle. The mechanism is HPA axis regulation and cytokine clearance. The single most powerful intervention here is sleep architecture, specifically slow wave sleep, because this is when both growth hormone secretion and the early cortisol priming cycle are established. Magnesium glycinate at 300 to 400 milligrams, taken 60 minutes before sleep, has robust evidence for improving sleep depth and reducing nocturnal cortisol dysregulation. Magnesium works as an NMDA receptor antagonist in the central nervous system, reducing neuronal excitability and supporting parasympathetic tone. This is not magnesium oxide from a cheap supplement aisle. Glycinate forms specifically because of its superior bioavailability and the additional inhibitory effect of glycine on the nervous system. There is also strong evidence for ashwagandha root extract, specifically the KSM-66 or sensorial standardized forms, which contain vithanolides at a minimum of 5%, at a dose of 300 to 600 milligrams taken in the evening. Vithanolides modulate cortisol production at the adrenal level and have been shown in randomized controlled trials to reduce serum cortisol by an average of 27% over 8 weeks. Counterintuitive finding. Many people with morning pain increase their caffeine intake to get through the day. Caffeine consumed after noon measurably disrupts slow wave sleep, not just sleep onset, and directly impairs the cortisol rhythm that is supposed to clear inflammation overnight. That afternoon coffee is contributing to the next morning's pain. This is not speculation. This is pharmacokinetic research on adenosine receptor blockade and its effect on sleep staging. Step 3. Drive collagen synthesis with precision nutritional cofactors. The mechanism is supporting the two-step enzymatic hydroxylation of collagen precursors that requires ascorbic acid and specific amino acid availability. The intervention is not simply taking a collagen supplement. Hydrolyzed collagen peptides at 10 to 15 grams per day, taken with 500 milligrams of vitamin C, consumed 30 to 60 minutes before movement or physical therapy, stimulates targeted collagen synthesis in tendons and cartilage by delivering the precursor substrates at the exact window when mechanotransduction signals are active. This is not theory, this is peer reviewed research from groups at Penn State and the University of Otago. The vitamin C is not optional. Remove it and you remove the rate limiting cofactor. The collagen peptides deliver nothing without it. Step 4. Activate the muscle pump to force synovial fluid exchange and lymphatic drainage. The mechanism is that synovial fluid, the lubricant inside your joints, does not circulate passively. It circulates through compression and decompression generated by movement. When you sleep motionless for 7 or 8 hours, synovial fluid stagnates. Inflammatory debris accumulates. The joint wakes up in a pool of its own metabolic waste. The intervention is structured gentle movement within the first 15 minutes of waking. 10 repetitions of controlled ankle pumps, 10 knee to chest pulls, 10 gentle spinal rotations in a supine position, and a 5-minute slow walk. Do not skip straight to standing and loading. Prime the pump first. Additionally, rebounding, a mini trampoline, for 10 minutes per day is one of the most effective low impact lymphatic stimulation tools available. The lymphatic system has no heart. It depends entirely on movement and gravitational shift. 10 minutes of gentle rebounding generates sufficient oscillation to drive lymphatic return through the lower limbs more effectively than 40 minutes of walking. There is a persistent myth that rest is the primary treatment for joint inflammation. For acute injury, yes. For chronic systemic inflammation, immobility is the accelerant, not the cure. Step 5. Target the inflammatory cascade with curcumin and the lipoxin pathway. Curcumin, the primary polyphenol in turmeric, specifically the curcuminoid fraction, has well documented inhibitory effects on NF kappa B signaling, COX2 enzyme activity, and interleukin 1 beta production. The problem is bioavailability. Standard curcumin is almost entirely metabolized before it reaches systemic circulation. This is not just about getting the right form, it is the reason most people say turmeric does not work. They are taking the wrong preparation. Use phospholipid complexed curcumin, marketed as Meriva or similar, or piperine enhanced curcumin with at least 95% curcuminoid content at 500 to 1000 milligrams twice daily, taken with a fat containing meal. At this dose and bioavailability, curcumin reaches tissue levels sufficient to measurably suppress inflammatory cytokines. Counterintuitive finding. Many people avoid fats when they have inflammation because they have been told fat is inflammatory. Saturated fat in excess is problematic, but curcumin and omega 3s are both fat soluble compounds. Avoiding fat when you take them is the reason they are not working. Here is where almost everyone gets stuck, the fear. The specific fear that drives middle of the night internet searches and the quiet dread that settles in when the pain does not go away. The fear that what they are feeling is the beginning of something they cannot come back from. A degenerative condition, spinal stenosis, rheumatoid arthritis, something that ends eventually in a wheelchair or a surgery table. Do not dismiss that fear. It contains a kernel of genuine signal. Morning pain after 60 can, in some cases, reflect serious pathology. The warning signs that warrant immediate clinical evaluation are pain that is severe and unrelenting at rest with no mechanical aggravation, pain that wakes you from sleep consistently and is not relieved by morning movement, significant unexplained weight loss accompanying the pain, pain radiating down one or both legs with associated numbness or loss of bladder or bowel control, and fever or systemic illness accompanying joint symptoms. If you have these, you need imaging, you need inflammatory markers, specifically CRP, ESR, anti CCP antibody, and uric acid, and you need them promptly. Request them by name. Do not accept let's monitor it if you are experiencing neurological symptoms. But the vast majority of morning pain in people over 60 is not those things. It is the systemic failure pattern I described. It is microvascular, inflammatory, and collagen related. Miserable and functionally impairing, yes. A death sentence, no. Do not ignore warning signs, but do not amplify the fear beyond what the physiology actually warrants. Now, here is something that changes the calculation significantly for people over 50. Three biological processes accelerate sharply in the post 50 decade, and each one directly worsens this picture. Estrogen decline in women causes a measurable reduction in collagen density throughout the entire musculoskeletal system, not just bone. Estrogen is collagen protective. Its decline is one reason why women experience a dramatic increase in joint and tendon pain in perimenopause, often attributed incorrectly to general aging. Testosterone decline in men reduces the anti inflammatory activity of androgens, impairs muscle maintenance, and muscle is the primary mechanical offloader of joint stress, and slows tissue recovery after mechanical load. And in both sexes, the decline in mitochondrial density in slow twitch muscle fibers after 50 reduces the body's capacity to generate the sustained low intensity muscular activity that drives lymphatic flow and synovial circulation. The clock on this does not stop, but it can be slowed significantly with the right daily habits. Here is the full action summary. Hydration 30 milliliters per kilogram per day, distributed progressively. 300 milliliters with 200 milligrams sodium 90 minutes before sleep. No exceptions. Nutrition hydrolyzed collagen peptides 10 to 15 grams with 500 milligrams vitamin C 30 minutes before morning movement. Omega 3 fatty acids 2 to 3 grams combined EPA and DHA in triglyceride form with your largest meal. Curcumin 500 to 1000 milligrams twice daily in phospholipid or piperine enhanced form with food containing fat. Supplementation magnesium glycinate 300 to 400 milligrams 60 minutes before sleep. Ashwagandha KSM 66 or Sensoril 300 to 600 milligrams in the evening. Vitamin C 500 milligrams with collagen and an additional 500 milligrams midday if your diet is low in fresh produce. Movement 15 minutes of structured morning joint mobilization before any loaded activity. 10 minutes daily rebounding for lymphatic drainage. Eliminate caffeine after noon. Emergency signals to escalate immediately. Unrelenting rest pain, neurological symptoms, systemic illness, unexplained weight loss. Request CRP, ESR, anti CCP, and uric acid by name. You can see that everything here is for your information and education. Your health picture is individual, and the most useful conversation you can have is with a clinician who knows your full history. If this video gave you something real, subscribe and leave a like. That is how this channel reaches more people. 100,000 subscribers is the goal, and every person who subscribes moves it forward. Morning pain after 60 is not wear and tear. It is a system in failure, and systems that are failing can be worked on.